It is a great pleasure for me to chair this wonderful session. Just some brief information before. This is a webinar where the third parties' views, products, or services are not, there is no endorsement. So let's go to the session. It's a great pleasure for me to introduce the speakers to eminent researchers and also personal friends over the many years of collaboration and time. And I think we are lucky enough to have probably the two most important researchers and clinicians in this field. The first speaker will be, and we have a little change in the program, Professor Susan Davis. I think, again, most of you know her already, but I would like to briefly introduce her. She is the director of the Monash University Women's Health Research Program. She's the head of Women's Endocrine Clinic, Alfred Hospital, Melbourne, and consultant endocrinologist. She's an international recognized expert on sex hormones and aging, including menopause and its health sequelae. She has more than 470 publications. Her epidemiological research across the adult female lifespan focuses on determinants of physical, psychological, and sexual well-being. It is very important that her clinical trials program has led to paradigm shifts in the understanding of testosterone in women, with current trials examining the role of hormones and on cardiometabolic health, cognition, musculoskeletal health, and sexual function. She has received numerous prestigious research awards, most recently the Elizabeth Blackburn Award of the NHMRC, Ross Honan Award of the Australian Heart Foundation, and the RACP College Medal. Professor Davis is a past president of the International Menopause and the Australasian Menopause Society and is an executive council member of the Australian Academy of Health and Medical Sciences. She's an advisor to the National Women's Health Council Australia and to the NHS Menopause Improvement Program Steering Committee. So, Susan, the forum is yours. And I just wanted to add that if you have questions, please send it to us so that we can, after the presentation of Professor Davis, try to answer already questions. Thank you.
Oh, thank you very much, Johannes. It's a pleasure to be here. I'm just trying to share my screen. These are my disclosures. Okay, so the things I would like to cover in this presentation are listed here, starting with androgen physiology and then talking about testosterone therapy at the end and the options. So in our research, we have used large population studies to look at androgen levels with age. And what we've found in studies in the last few years is that testosterone, as was thought previously, declines between the ages of 18 and 40 years and increases from the age of 70 years up through to 90 years. And that middle section was a bit of a black box because up until recently, there haven't been papers that have looked at large unselected samples of women to document androgens at midlife. So we recruited over 8,000 women across Australia. We were able to stage 5,500 of them by their menopause. We excluded women with any factors that would affect their testosterone levels, and we've reported their androgen levels recently. And what we found was that testosterone levels still continue to decline from the age of 40, reaching a really subtle nadir around about the age of 58 to 60, and then slightly increase again. And this is while you can see in the second panel, testosterone levels, DHEA levels are declining and androstenedione is declining. Now this decline to the age of 58 and then subtle increase is quite interesting because when I look back on other papers, I see it in other studies, but people haven't really reported it because I think people have thought it was an error. or a chance finding. But in fact, if you look at all the other studies that have used, or the one study by Robin Haring that used mass spec, and our study in the past where we used immunoassay, we saw exactly the same thing, this decline to the age of the late 50s and then a gradual increase after that. What we also saw is when we restricted the analysis to women around the age of menopause and divided the women by menopause status and adjusted for age, whether we use the standard straw criteria or a modified straw criteria, testosterone levels do not change with menopause. So I think we can be quite confident that there is no effect of natural menopause on testosterone levels. So that's the first point I'd like to make. The second point is, and sorry, it's gone a bit askew, but blood androgen levels do not equal tissue levels. And this is because blood levels don't tell us what's happening in the cells. In the cells, a whole lot of complicated things are going on. Androgens act through cell membrane receptors, acting through genomic pathways in DNA, and the action of androgens and other sex steroids is really modified by coactivators and repressors and a whole lot of things that happen at the tissue level. So a blood level of testosterone is not necessarily a tissue action level of testosterone. So we don't measure serum testosterone to try and diagnose low testosterone. There's no cutoff blood level of testosterone below which a woman has low testosterone, and there's no established lower limit of normal. So there is no defined androgen deficiency in women, despite what is being promoted on social media. And I see that there are three key reasons to measure testosterone in women. Firstly, obviously, to investigate hyperandrogenism. Secondly, we always measure testosterone before treating with testosterone to exclude women with unexpectedly high levels, and then to monitor testosterone levels during therapy. But we don't measure testosterone or any of the preandrogens for a diagnostic purpose for low levels. Okay. The other thing we've done in our cross-sectional study is to look at sexual function. I'll just go back for a second. So we had, as I said, just on 4,500 women whose menopause status could be very clearly assessed by their bleeding patterns. They all completed the profile of female sexual function and a distress scale, and we then had a lot of variables that we knew about in these people. And what we found, and you can see here, and this is recently published work, is on the left the prevalence of the sexual difficulty, and this is the prevalence of the difficulty combined with distress, so dysfunction. So you can see low desire increases with age, and then plateaus after the age of about 55 to 59. And low desire with distress also increases with age from about 13% in prevalence up to about 16.7%, and then plateaus. Arousal dysfunction continues to increase with age into women, again, really plateauing from the late 50s, and arousal dysfunction peaks at about 16% in women aged 55 to 59. Orgasm difficulty increases with age, but the dysfunction doesn't actually vary much with age. The other really interesting thing I'll point out is when we look at women aged 40 to 44, these prevalences of sexual dysfunction were not actually different to what we saw for premenopausal women in their late 30s in our previous study of premenopausal women. So there's real consistency between studies. Sexual responsiveness, again, increased with age as a difficulty, but the prevalence of dysfunction, so women with poor sexual responsiveness and associated distress, does not vary across with age, vary with age very much. And sexual self-image increases with age and peaking in women in their late 50s. Of the women, I'm going to go back momentarily because, whoops, I'm going to go backwards here. If you can see here, of the 30% of women in 50 to 59 with sexual difficulty, only about half of these women actually have low desire with dysfunction. But what's really interesting is that if you look at sexual self-image, of the women who had poor sexual self-image, 85% had poor sexual self-image with distress. So having poor sexual self-image is much more predictive of a condition with distress than, say, low desire. Hope that makes sense. When we looked at women according to menopausal stage, what we found was that desire dysfunction, arousal dysfunction, and self-image dysfunction all doubled in prevalence between pre and early perimenopause. So here you can see the prevalence of low desire with distress is about 9% in premenopausal women, but by early perimenopause, the prevalence is double. The same for arousal dysfunction, prevalence doubling between pre and early peri, and they're not changing much, and sexual image dysfunction doubling between pre and early peri, but testosterone levels are not changing. So something else is going on other than a change in testosterone level that is causing this increase in prevalence in sexual dysfunction between pre and early perimenopause. And these analyses are adjusted for multiple variables. And really, this is a very sort of robust finding. The factors that were associated with low sexual desire with distress were being partnered. So if you're partnered, the probability that you'll have low desire with distress is double compared to being not partnered. These are all independent variables. Moderate to severe depressive symptoms are a very strong predictor of low sexual desire with distress. Current antidepressant or anxiolytic use is associated with an increased likelihood of low desire with distress independent of depressive symptoms, as is vaginal dryness. So these were the main factors. We also looked at sexual abuse. We looked at whether women were LGBTQIT+, a whole lot of other factors, but these were the predominant statistically significant independent factors. Now, the other thing is we talk about treatment of sexual desire dysfunction as though we can suddenly give a treatment and we're going to make it better. And we forget that desire dysfunction is a combination of low desire and being distressed about it. And the things that predict low desire and the response, which is distress, overlap. However, we've got to understand that the low desire is the biological target, although there are a lot of other factors that trigger low desire, not just biology. But how you respond to the low desire is the psychosocial aspect. So all the research has been designed to look at, say, testosterone to treat HSDD. But why would testosterone treat distress? It's not going to make women feel differently about their low desire necessarily. How they feel about their low desire is determined by a whole lot of other factors. The testosterone may simply treat the low desire, and yet we expect everybody to have their distress improved. And it's a really false construct that we've tried to put into these circumstances. So what's the evidence that testosterone is beneficial when I've just said that desire with distress doubles between pre and perimenopause when testosterone doesn't change? Well, we do have evidence from randomized controlled trials that testosterone can be helpful. And the analyses, and many of you have seen all this before, so I'm probably repeating a lot of information you've seen. We looked at studies of at least 3 months duration. We included unpublished data, and we looked at all the robust clinical trials. We saw that satisfactory sexual events increased with testosterone for women with low libido compared with comparative therapy. And you can look here the same. We look at these subtotal numbers, and you can hear in the meta-analysis, sexual desire improves with testosterone therapy compared with comparator. Arousal improves compared with comparator. Orgasm improves compared with comparator therapy. And sexual distress did decrease in these studies compared with comparator therapy. What we have seen is across the board with these studies, if you use a physiological dose of testosterone, the impact is delayed and you do not see the maximal benefit until about 12 to 14 weeks. And we see that with the improvement in desire, the reduction in distress, and social overall activity. So women do need to be told that if they're going to use a physiological dose of testosterone, the impact is not immediate. The other thing is that more is not necessarily better. So this is 2 dose-finding studies, one in postmenopausal women and our study in premenopausal women, comparing placebo here in 2 different groups with 3 different doses of testosterone. These were patch studies. This was a testosterone skin spray study. And what's really interesting in these 2 studies, the dose of testosterone that gave physiological levels, the mid dose, here it was a 300 microgram patch, here it was a 90 microliter spray, it was the mid dose that actually gave the benefit. And higher doses were not only not more effective, they were just no different to placebo. And it's fascinating seeing this in 2 completely separate studies. So there is a sweet spot for giving testosterone, and more is not necessarily going to be a better effect. And the same was seen in the study of Brownstein et al. When they looked at not just desire, but also arousal. And the other outcomes were not significantly different to placebo in that particular study. There are androgenic effects with physiological dosing, and women may develop acne and they may develop increased body hair growth. In the clinical trials with physiological dosing, there was no voice change, although voices were not recorded. It was self-reported. There was no increase in clitoromegaly, and there was no increase in alopecia. There was, however, a slight tendency for women to have an increased weight. Modest, but women should be warned of that. And this may be weight gain, increased muscle mass, or fluid retention. We don't know. The global consensus statement is that testosterone therapy should not be non-oral, have established pharmacokinetics, and not cause supraphysiological blood levels. And any testosterone preparation that results in supraphysiological levels are not recommended because of the risk of unwanted side effects. In Australia, UK, New Zealand, and South Africa, there is a transdermal regulator-approved 1% testosterone cream. Now, it's important to note that this cream has no absorption enhancer, and women do not need to be on estrogen to be eligible for treatment. This is very different if you're in a country where you don't have a female-approved therapy and you're using male formulations. The male formulations have absorption enhancers. So you can't compare the doses exactly. So the starting dose in Australia is a 5 milligram dose of the Australian cream, which equals about 2.5 milligrams of the male formulations. So you have to cut the dose down for the male formulations compared to the dose we use in Australia, because of the problem of the male formulations all having penetration absorption enhancers. The other thing is there's this wild enthusiasm for testosterone implants. Now, this is one study done showing the unpredictability of testosterone levels with implants. So this is a study of 4-week serum testosterone levels at 4 weeks after 100 milligram testosterone implant in women. And you can see the blood levels range from like 75 nanograms per deciliter, basically into the male ranges at 350 nanograms per deciliter, and the differences between individuals. And here you can also see in one individual that the range of levels even over 24 hours. So people are told you get this really lovely steady state with testosterone implants. That's not true at all. What you do is get blood levels all over the shop and very high blood levels. In that particular study that I just presented, the conclusion was that there were no adverse events. But they then went on to list and say 86% of patients had increased facial hair, some had severe facial hair, 11% had increased acne, and some even had voice change. So there are adverse events. This is a US study looking at women who had received testosterone or hormone pellets, most of whom had testosterone pellets. And in this particular study, 380 women, 84 women, the nadir in testosterone was 66 nanograms per deciliter, which is above the normal female range, with the peak being nearly 200. And in the women with pellets compared to FDA-approved therapy, look at the prevalence of mood swings, anxiety, breast tenderness, hair growth change, acne, and it goes on. Side effects are common. So pellets are not mostly good for women. So overall, the treatment principles are prescribed transdermal therapy, pharmacological doses, keep an eye on the blood levels, review your patients clinically as well as biochemically. If there's no benefit by 6 months, stop therapy. And as long as patients are on therapy, you must monitor them. I'm not going to talk about DHEA, but basically conclude by saying low sexual desire with distress increases in early perimenopause and peaks in the late 50s. You need to look at all the determinants of low desire. Testosterone may be effective for sexual desire in postmenopausal women. The associated distress response is variable, and I've talked about the treatment. And the World Congress on the Menopause is in Rio in September, October next year. And I'm sure Rossella, as current presidency, is going to invite everybody to join. And I will stop sharing at this time.
Thank you very much, Susan, for this excellent overview and especially the critical evaluation of a very complex problem, as you have shown, where these multifactorial pathogenesis, if I may say, of desire and arousal disorders, you have taken it very, very clearly up. Thank you very much. I don't see any questions for the moment.
Maybe, Johannes,
Yes.
we can comment a little bit more, if we have the time, on these attitudes that some people now they have to measure testosterone, to follow up with the measurements, etc., etc., etc. And this is really a standard of practice that is not supported by the evidence. So I would like maybe Susan to have the opportunity to comment even more on these attitudes we have out there, especially in Europe. I see a lot.
Yes, look, women are going round to their doctors and saying, I want you to test my testosterone. And doctors are testing the testosterone saying, oh, your level's low. Either I'm going to give you treatment or they send them to specialists like me for treatment. And the thing is, we have done systematic reviews of the literature. There is no evidence of any association of testosterone with sexual function, with well-being. When we've done our systematic review of the literature looking at the associations with muscle mass and muscle function, no association. No association with blood levels of testosterone and cognitive performance. So there is no evidence. There is no evidence that a blood testosterone level at the low level means anything. And as we know, most of the laboratories are using immunoassays that cannot tell normal from low anyway. So they're very imprecise at the lower level in women. And so the blood levels are really meaningless. We use testosterone assays to monitor testosterone therapy and to investigate women with androgen excess. They're reliable at the high and above the high end of the female range, but they are not of any diagnostic use. And it's a real concern that people are wasting time and money doing this and giving patients misinformation as though they've got some medical condition because their testosterone's low.
If I may also add a question from my practice, there are women are coming and saying, well, can I try testosterone because it has helped a friend regarding her sexual life, etc. And some of these women very much believe in it, and here it comes to my question of a placebo effect. Yeah, is there a so to say, well-controlled trial looking into the effect of the placebo effect? I believe in this. I believe in this treatment. I believe in this drug, and that, as you were saying, the subjective experience is, of course, very much influenced by what I believe. Yeah.
Oh, look, the placebo effect is very real. And in some very large studies where there was a lot of caution not to embellish, not to overstate the effects of testosterone, the placebo effect was not so high. And you saw a benefit of testosterone. But there were a couple of very large studies, each involving 500 women. In each study, 250 got active therapy and 250 got placebo. The women in the study were told they had a 50% chance of getting placebo. And yet, because of the nurturing and the caring of the women in the studies, the effect of testosterone was just as we saw in the patch studies, but the placebo was just as good. The placebo in those studies was just as good as the testosterone, even though the women knew they had a 50% chance of getting placebo. So I think women do not want to know about the placebo effect. They're refusing to know about it. So the bottom line is there is an effect of testosterone. It is modest, but there can be a dramatic placebo effect as well.
I just received one question. I don't know, I still have time. It's a colleague from Turkey. Thank you for all. I'm from Turkey. We have in our country no estrogen TTS forms, as we have not TSTTS forms. How do you suggest we dose testosterone? I don't.
So if there are no transdermal at all,
yeah,
I think it's very difficult because I think it's very challenging to treat women with testosterone. If you have no transdermal forms, you can't even titrate with a male formulation. I'd really counsel against intramuscular and certainly against pellets because they're compounded these days. There's not even a pharmaceutical grade company that's making pellets. So I think it's most unfortunate and very difficult.
Yeah. Okay, and last question, if I may, because it will overlap probably also with Rossella. I mean, we do have tibolone. Is there a place for a sort of an androgen effect via this combined preparation, which I think in some studies, I mean, you have done it also, it has proven some effect on sexual function.
We did a head-to-head study of tibolone versus transdermal estradiol and norethisterone patches. So it was a double-blind, double dummy. So everybody got a tablet and a patch. And some people got tibolone and a dummy patch, and some people got an active tibolone, an active patch and dummy tibolone tablet. And there were women with low libido that bothered them. And the only difference between the two groups was in responsiveness. There was actually no improvement, no difference between tibolone and the estrogen progestin patch in desire arousal.
Okay.
So it may have an effect in some women, but it's pretty subtle.
Okay. Okay.
Yeah, I will show the study, Johannes.
Okay.
just to explain better, but it's absolutely true. If I may comment on the placebo effect, I have to tell you that in my experience, the women, when they are on testosterone, they do better in terms that they have the motivation to do things they are helping.
Yeah.
So they do more exercise, they do more intellectual activities, because they want to follow that track. And this is probably one of the reasons
Yeah.
why the
Yeah.
testosterone can be effective, in my opinion, as part of the placebo effect.
Yeah.
I fully agree with this. Is the psychotherapeutic effect of testosterone.
Yeah. Well, thank you
Okay.
very much. And I am going to now
Yeah.
disappear.
Oh,
And
Susan, thank you
I
very
really
much.
appreciate it.
Thank you very much.
Sleep
Bye all.
well, rest
Sleep
bien.
well. Sleep
Ciao.
well. Okay.
Ciao, ciao.
Ciao,
Okay.
ciao. Bye bye.
Bye bye.
Now it's my pleasure to introduce the next speaker again. Everybody knows her, but I think it is worthwhile just to remind you of all the things she has done. She's a full professor of obstetrics and gynecology, chief of the Research Center of Reproductive Medicine and Gynecologic Endocrinology Menopause Unit at the San Matteo Foundation, University of Pavia. Her major interests are in the field of psychoneuroendocrinology of female reproductive and post-reproductive life, with a special focus on women's sexual health. She has published around 450 scientific articles, and she's a well-known speaker on women's health from adolescence to menopause, a life course approach. She has been very active in many international meetings and research projects in the field of contraception, menopause, and female sexual dysfunction. She is past president of the International Society for the Study of Women's Sexual Health. At present, she is permanent member of the advisory board of the International Society of Gynecologic Endocrinology, ISGE, as you know, and of the International Academy of Human Reproduction, AAHR. And she is president of the International Menopause Society, IMS. Dear Rossella, the floor is yours.
Thank you, Johannes. It's such a pleasure to be here with you, and I think it's even better to speak after Susan because I will collect some of her clues in order to understand even better the role of estrogen. Also, because we have always to keep in mind that testosterone is transformed into estrogen. The reason why, in my view, estrogen is so important and is even more important probably than testosterone in understanding the impact of the neuroendocrine system into the female sexual function and response and behavior overall is related to the fact that, as you know very well, estrogen, they have a multisystemic effects, as you can see on the left end of the slide, because estrogen, they affect very much the neurotransmitters and the neuromodulators within the central nervous system, and it has also an incredible role in modulating the physical neurovascular and neuromuscular response that can be seen during our life. So there is an overall impact on all the biological substrates that can be involved into human sexuality. And the model we have to study the impact of estrogen, you see that on the right end of my slide, it's really the menopause. So what happened at the time we have this significant change, they are so clear in a woman life, in which you have to go on in your life for more than 30 years nowadays without the effect of estrogen in your body. And we know very, very well that we have some adjustment at the level of the central nervous system and developing climateric symptomatology. And we have an impact on the genital tissue and on sexual function overall, with the two major symptoms we can find one, Susan already discussed, decreased sexual desire, but very, very important is sexual pain, the so-called dyspareunia, that is strongly related to the vaginal dryness and all the other symptoms. They are part of the genitourinary syndrome of menopause, but we have always to keep in mind that sexual pain may have very different etiologies. But for sure, this is something we see when we have the decline of estrogen. As I told you, I like to have the introduction of Susan because we always have to look at this endocrine change we have with the menopause and the impact that can have on sexual health in this yin and yang perspective. We have learned that androgen that goes down with aging, and this is not something related really to the menopause, but it happened at the same time that menopause takes place. And so many of the symptoms we observe in our practice, and including the sexual dysfunction, they may be the results of a combination of both. This is something we see sometimes, for example, in women, they enter menopause early, in which they start suffering more from some kind of symptoms, especially sexual dysfunction, when they enter in a age following 40 and even at 50, in which it's quite normal to enter the menopause, because probably there is a combination of these two dimensions, and we are starting investigating what can be attributed to low estrogen and to menopause, and what can be attributed to the aging process, including the decline of androgen. As I told you, it's always very, very difficult to separate the effect of the two, because the endocrine milieu acts as a whole on the neuromuscular and neurovascular circuitries. They are involved in the three dimension of the sexual response. And there is also an additional benefit of the endocrine milieu on what we may name physical and mental well-being. We have seen, for example, as Susan showed you very well, the comorbidity with depression and with some use of psychoactive agents, etc. So this is the reason why we really need the biopsychosocial model and a multidimensional approach. And as Johannes was alluding to, because he's an expert on this, we cannot study hormones into a vacuum. We have always to consider all the other different intrapersonal and interpersonal dimensions. Estrogen have been studied in the central nervous system, mainly in animal models, and you know that we cannot translate very much animal models into human sexuality. But when we look at the different components of the sexual response at the level of the central nervous system, at least in the animal models, we were able to separate quite well the impact of testosterone as an initiating factor into the desire, the mental arousal, and some dimension of mental satisfaction, the perception of satisfaction related to the peripheral orgasm in the brain. And what's the role of estrogen in general? To permit that all these things happen. In some way, we may say that estrogen contribute to the sense of feeling desire that is initiated by testosterone. And we have always to keep in mind that what we have learned is that progesterone that doesn't, it's always hands in hands with estrogen, may have a modulatory activity, and they may influence the receptivity of the woman, both at the central nervous system and we will see at the peripheral level, because there is a sort of counteraction of progesterone on the permitting effect of estrogen. And this has been studied by trying to investigate this fluctuation on the balance of many neurotransmitters, essentially dopamine, serotonin, noradrenaline, but even the GABA system and progesterone metabolites are especially very active in the GABA system. But we don't have so many data in women, however. So this is just a cartoon that try to explain the role of sex hormones within the brain. It's a sort of priming that help the brain to be responsive to sexual incentives. And you have a neurochemical state that more likely induce the sexual response. But we know, for example, from our clinical practice, if we have new sexual incentives, even though maybe we are menopausal, we are able to feel desire, arousal, and even to better respond at the level of the genitals. So the hormones are only a part of the story. At the level of the genitals, hormones has been studied better, also because it's easier to at least measure some dimension of urogenital well-being. Think about studying vasocongestion with vaginal plethysmography, or looking at the genitals with specific scale to try to quantify vulvovaginal atrophy, or GSM as we want to call. We can use also some ultrasound approach to measure the blood flow. But exactly as Susan was saying, with the correlation with testosterone, what we know nowadays is that it's very difficult to correlate what we see and we measure with scale, or we see in clinical interview, with this, let's say, biomarker of the ability of the genital to have a sensation, to be vasocongested and lubricated. But there is absolutely no doubt that steroids, they exert a trophic effect on the genital, and they are able in some way to set the threshold of the peripheral tissue response to the external and internal stimuli, always throughout a neurochemical array. So we really need to see at hormones, but always to see also to neurotransmitters and neuromodulators, because the same neurotransmitters, they are involved in the brain, especially serotonin and noradrenaline. They are also released at the level of the peripheral nervous system to modulate the arousal and the orgasmic platform and orgasmic reflex. And there are also other modulators that we know very much because they are involved into a vasoactive role, and also a contraction. For example, prostaglandin, we know they are so important for muscular contraction, both of the uterus and even of the pelvic floor, and nitric oxide, that is a gas that has been studied so well in male. But you remember again, when we try to use a drug to improve nitric oxide into the female genitals, we didn't succeed very much, especially in the absence of estrogen. And even other neuromodulators has been studied in relation to estrogen, vasointestinal peptide, and neuropeptide Y. They are involved in the lubrication process. But at the end of the day, you see no significant correlation between the subjective response and the objective response. So the point I want to make is that it's very difficult to separate the effect of estrogen from the effect of androgen, because they goes hand in hand. They act centrally and peripherally together to modulate desire and arousal. And we know how it's difficult also to really separate, for example, desire and arousal in the brain. You know very well that there is a lot of discussion going on if it's important to keep these two entities separated. In the new DSM-5, we can discuss a little bit these two dimensions, they stay together, and then we have a peripheral dimension. So it's very, very complicated, and we have always to look at a vicious negative circle or a positive circle, in which if you have a good desire due to the neuroendocrine balance, probably you will have more arousal, and therefore your peripheral response will be facilitated. Whereas if you have pain, for example, if you don't have enough vasocongestion and sensation into the genitals, sooner or later, of course, you can develop also low desire. So it's not only the effect of the hormones per se, but it's really the behavior that can influence the sexual response of women. Another very important point is, however, that we have to consider that there are some specific effects of androgens. They have emerged quite recently. And this specific effect of androgen, as you can see from this cartoon, are mostly related to the vulvar component of the sexual response. Because when we study what happened into the menopause, we always consider the effect of low estrogen in the genitals. And apart of the lubrication we already mentioned, remember that there are other two components that can influence the sexual response. One is the inflammation, what we name atrophic vaginitis, because you should remember that the vagina, in the absence of estrogen, they can become very pale, very thin, very fragile. Also because you have a thinning of the vaginal epithelium, because you lose elasticity, etc. But remember that you can have also some vaginal discharge. You may have inflamed tissue that can give you burning and petechiae, other aspects that can be involved. And this is the reason why, in order to improve sexuality, we really need to replace estrogen, because if we believe that sexual function is a vicious circle, and dysfunction comes from the pain that the woman can feel in the genitals, for sure we have to replace. But sometimes it's not enough. And why is this? Because we have also pain, for example, in the introitus. We do not improve enough the lubrication. Why? Because we know that androgens contribute, for example, not to the mucin production on one end, but contribute significantly to the neuromuscular components of the sexual response, because we know that in absence of androgen, we have less nerve density, we have a poor strength of the muscular layers of the pelvic floor, and at the end of the day, the lubrication that you can see during the sexual response is not just the baseline lubrication, but it's really the neurovascular response that is mediated by the pelvic nerve efficiency. And experimental data suggest that when you lack androgen, you have less pelvic nerve mediated blood flow. So at the end of the day, therefore, we really need to consider that when we talk about estrogen and sexuality, the most important biological dimension that we have to target is genitourinary syndrome of menopause. There is a relationship with the hypoactive sexual desire disorder that Susan was alluding to, but we have to put all this into the whole picture. And we have already seen the altered body image and many other aspects. So it's not so easy to study. But we can treat, and we have to consider that optimizing urogenital health is really a masterpiece. It's really the first thing you should do. If women, they have sexual disorders, and you have to try to optimize urogenital health before of everything. And of course, if a woman she's also symptomatic overall, it's very important to consider menopause hormone therapy containing estrogen and progestogen if the woman has the uterus. Because, but as I will show in a minute, and this is really an anticipation of the new guidelines and recommendation that International Menopause Society will release in 2-3 days online in Climateric. And think about it, if you go to the website of the International Menopause Society and even on Climateric, you can find the full documents, the full bunch of literature we use to revise the issue. You see very clearly that when you want to improve sexual health and GSM as part of the management of improving sexual function, you have to consider that we have not so many evidence of a positive role of menopause hormone therapy because the benefits is generally small to improve the overall sexual function. And even when we treat GSM with estrogen, I will show you in a minute, yes, we improve, for example, the dryness, we improve the dyspareunia, but there is insufficient evidence of improvement in overall sexual function. And this is probably because so many other aspects are taking place, and we have to consider, as you know very well, the partner as well. So it's not so easy to give a quick fix to women. But when we analyze the different treatments, before the Turkish colleague was asking about the transdermal route, it's true that the transdermal routes of hormones, and we were discussing testosterone transdermal because of safety, but we should discuss the transdermal estradiol for efficacy. Because even though the effect is small, I have to tell you that is higher the effect of estrogen when you prescribe transdermally. This is a post-hoc analysis that was performed comparing the effect of conjugated equine estrogen against placebo and the effect of transdermal estrogen against placebo on sexual function. And you see that both treatment, they improve not so much, but they improve that minimal effect on the different component of the sexual function index score that has been used in this trial, but the impact of transdermal estradiol is a little bit higher. And this was significant. And you know that one of the explanations is that sex hormone binding globulin is less increased by the use of transdermal estrogen, and probably the availability of androgen into the circulation and into the tissue, as Susan told us, is a little bit higher. We have to keep in mind always that even the nature of progestogen influence the amount of sex hormone binding globulin we have into the circulation and therefore the amount of free testosterone. But I have to tell you that we don't have so many good comparison of the effect of different progestogen. Think about more androgenic and more anti-androgenic or neutral on women's sexuality. And so probably we should study more this subject nowadays that less women are so much afraid of taking hormones. There are some data with a new treatment that is available in some countries in which we use conjugated equine estrogen that, even though they are oral, but they can improve a little bit sexuality against placebo, and in this case is associated with basedoxifene. So we can use the treatment that we name T-sac without the use of progesterone, because progesterone, we said that sometimes can counteract a little bit the effect of estrogen. And you see that in this trial that was it's an analysis that was conducted in a pivotal trial as a secondary endpoint, the sexual quality of life tend to improve against placebo, even though, however, only few items reach statistical significance. And you see, especially ease of lubrication. But if you look at the other component of the sexual response, there is not so much impact. But in any case, you see that this approach can be used. Then I included the Tibolon because even though, as Johannes was alluding, we know that Tibolon is not a real, it's not a combination of estrogen and progestogen, but is a synthetic drug that can be named selective tissue estrogenic activity regulators, because we know that depending on the tissue where tibolon is metabolized, it can have a different potency in terms of estrogenic activity, but also some of its metabolites can behave, for example, as a progestogen, and in this is the reason why we don't need any endometrial protection, because tibolon can behave, for example, as a progestogen into the uterus. It has been studied very, very much, because you have to keep in mind that, as Johannes were saying, tibolon is out there in the market since 35 years in many countries, in Europe, in Latin America, etc., etc. Only US lack the availability of tibolon as a major country. And so we perform over the years so many trials, even a trial on sexuality. And what we have learned from some research that were performed in the past, that tibolon has also some kind of androgenic effects, because one of its metabolites can act as an androgen. This is the reason sometimes why we believe that this is a menopause hormone therapy that has a dual action, and in the brain especially can act on mood and sexuality. You see, this is a study we conducted some years ago to try to compare the tibolon with the most efficient treatment that we had at that time on sexual health. That was transdermal estrogen plus norethistron acetate, because norethistron acetate transdermally and orally is a little bit androgenic, and so we believe that that was the best comparator in terms of treating women with some kind of dysfunction. And you see that we found some little difference over time with tibolon and with estrogen, but not so much difference really. And so we may say that these two compounds probably they are the best menopause hormone therapy we can use in clinical practice if we want to boost a little bit the sexual function of women. And for example, in that study, we measure also the clitoral blood flow circulation more or less 20 years ago. And you see there is a little effect at 6 months that is more evident with tibolon, but that effect on the peak systolic velocity and even the end diastolic velocity, so meaning the amount of blood that stay in the genital of women, and this was at baseline because we couldn't do any sexual stimulation according to my ethical committee at that time, but there was no correlation whatsoever with the sexual function. So this is the reason why we stopped at that time using to measure these variables. And now I know that other authors, they are back to try to find some kind of relation with estrogen or androgen, but this kind of study are not so easy. However, this is the study we conducted with Susan Davis and in which there was some kind of better response in this per protocol analysis in women with natural menopause in the so-called LISA study. We consider, as Susan was already mentioning, a composite subscore of the female sexual function index. Yeah, you see a little bit better performance in terms of more satisfaction, a better perception of the sexual response and responsiveness. But as you can see, the difference is not so strong. So we cannot say really that Tibolon is superior. But I have to spend also a few words on estrogen in terms of treatment of genitourinary syndrome of menopause. And also a couple of compounds, they are under the umbrella of the estrogen effect. But as you heard from Susan, she said, I will not talk about the HEA systemically because there is no evidence overall. As you know, the HEA is an androgenic precursor that can be converted into the tissue by the concept of intracrinology in androgen, but also into estrogen. So they can, and DHEA, vaginal DHEA, goes into the umbrella of the local treatment and may have also an estrogenic effect. So it's nice to show some data about that. And also, we don't have to forget another SERM that is not basedoxifene, that is used to protect the endometrium with conjugated equine estrogen and has a specific role on the bone. This ospemifene SERM has a specific effect in the vagina. And the effect that ospemifene has is an estrogenic effect. So it's very good to mention in this context. I think you are all aware of the variety of estrogenic products we have for the vagina, depending on the different availability and access in different countries. They go into the umbrella of local estrogen therapy. We have estradiol, vaginal tablets, pessaries, cream and ring. We have estriol, vaginal cream, pessaries, combined also with lactobacillin in some country. We may have conjugated equine estrogen cream and even a very, very mild estrogen that is named promestrian in cream and pessaries. And these treatments, they should be used regularly, of course, only for the urogenital component. And progesterone is usually for daily use, and that is DHEA, sorry, because I didn't put the acronym in the progesterone, and ospemifene is one oral tablet. But you see that the effect of these compounds on the sexual function after menopause, as I told you in the slide of the recommendation, is very, very mild and has not been so well studied. This is a review we recently published in Maturitas, in which you can see there are only 3 studies well conducted, one that was double blind, you see up there, another one also that was double blind with placebo, and another one that was an open label parallel group in which the tablet, estradiol tablet, were studied. The higher dose, the one that we don't use so much, 25, then also the 10 microgram against placebo, they were studied. And there was a study in which they compared conjugated equine estrogen cream even with a cream with testosterone, and in which the endpoint, you see here on the right hand, was sexuality. But you see, very short in time, 8 weeks, 12 weeks. Yes, you have a little significant increase in the scale, in the FSFI, in other dimension that we can measure with MEN-QoL, for example, sexual function domain, another scale that measure quality of life associated with the vulvovaginal atrophy condition that is named DIVA. There is a significant effect against placebo, but it's not so much to really support. And it's true also in a specific category of women. They are the women that we can try to improve a little bit their sexuality with local estrogen in breast cancer patients. You see, only 2 studies that were conducted, and only one randomized control double blind. The other one was open and was associated with the testosterone cream. So we cannot really say that we improve so much. And last, I want to show the data we have on the HEA locally, in which you see that this manuscript was published, in which all the different dimensions of the sexual response you can measure with the female sexual function index were analyzed, and you see an improvement against placebo. And this is very interesting because that can be due to the fact that you have this dual activity, estrogen and androgenic metabolism. If you think about what we said in terms of nerve density, in terms of genital arousal, because all the different domains of sexuality, they are improved. But of course, this is only one study that was published in a pivotal trial of the marketing of the HEA and 12 weeks. And here you see better the results I was alluding in terms of ospemifene. Ospemifene has been marketed for vaginal dryness, but you see that has data also on sexual function. And it's interesting to observe, as usual, that the effect on the tissue, of course, is higher, lubrication, pain reduction, but then you may have also an effect on the other domain. But again, also this trial was conducted only 12 weeks. And last piece of information is really to remember you that we can use estrogen also on the vulva, because we have more androgenic receptor on the vulva, but we have also estrogenic receptor. And there are some studies, because this is not the indication, because local estrogen products usually they goes into the vagina. But we know that the receptors are there in the vulva. We have learned that very much by studying specific category of women. The one, they are not menopausal. The one, they develop some kind of vulvodynia, vulvovestibulodynia, when they are taking hormonal combined contraceptive. And there are some data out there suggesting that these women, they do not respond so well in terms of sexual function when they are on contraception, because they have some kind of polymorphism in terms of estrogen and even androgen receptor into the genitals. There are not so many data on this concept, but we have to consider that maybe intracrinology, receptor sensitivity, and even other aspects of estrogen metabolism and even androgen metabolism can be involved in the fact that some women, they feel more pain into the vulva in comparison to the pain into the vagina. And indeed, in a category of women that has been studied very much, usually they are breast cancer patients, but now we have data also in women, they are natural menopausal women. When we use estradiol cream or even estriol cream, I didn't put all the data because otherwise it was too long, we can really improve our ability to respond and to don't have sexual pain if you use and you apply estradiol cream into the vestibule, even though we don't have products that are specifically approved for this indication, but we can do in real life practice. So in conclusion, my dear friend, both estrogen and androgen, they play a role. The evidence we have in postmenopausal women is there for many different treatments, but it's not so strong. There's only 1+. And what we lack, it's really a specific evidence, for example, in women, they have premature ovarian insufficiency. And we should study better this category of women where we apply the same criteria of natural menopausal women, but we lack a real good evidence-based data. And the rule is really the biopsychosocial models. And now I'm ready to take your question. And yes, of course, I invite you to Rio in next year at the end of September for the 20th World Congress of Menopause.
Well, thank you so much. Like always, Rossella, wonderful overview, an enormous amount of information which we have to digest. And thank you very, very much. I received already a question from our colleague from Turkey. Thank you very much. This is the first time I hear about promestrien as estrogen therapy for GSM. Can you give a little information about?
Promestrien is a very, very weak estrogen that has been tested also in some studies from the past in breast cancer patient because it's a very, very, very low absorption. It stays very much in the tissue. It can be available in cream and suppositories. And, only in few countries this drug is available, unfortunately. We use a lot promestrien in, I can tell you, in women older because it's very, very mild. And as you know very well, when the tissue is very atrophic, if you use a dose of estrogen cream or you use more strong estrogens such as estradiol, and by the way, estradiol cream is not available absolutely. You should prepare compounded, okay? What's happened is the tissue is so atrophic that, first of all, you can have some side effects. So women, they can feel itching, burning, and you may have even acute candida, okay? Candida disease, because you go back to estrogen all in once, and you may develop some side effects. But also you have a significant absorption because the problem is that as much the tissue is atrophic, as much you absorb the product. So as you know very well, now there is no black label anymore for local estrogen therapy because we know that we have plenty of data out there suggesting that local estrogen therapy, they are safe for other endpoints. Think about breast cancer, thromboembolism, or endometrial proliferation, etc., especially the one low dose. But it's true that for the first, let's say, 8-12 weeks, unless you reinduce the receptor into the mucosa, you may have a significant absorption. So there are some women that say, I feel breast tenderness, okay? And you don't have to deny that. You have to say, listen, don't worry. You wait a little bit and you will see that this side effect will fade. Why? Because the product will not go into the circulation. So if you use promestrien is so poorly absorbed that you don't have these side effects at the beginning. And this is particularly true in severe atrophy. So I hope you may have in the future in your country, I hope the renaissance of treatment in the menopause can help more countries to have access to products. And I hope that pharmaceutical company, they will understand that because, as you know, the crisis we had in treating women with hormones 20 years ago was negative for introducing products into different markets. And this is the reason why women are underserved. And this is the reason why international society should be there to stand up to protect women and to stimulate the governments and the companies to really market good products, safe products for women, because we can make a big difference.
Thank you very much. And our friend from Turkey responded, and he agrees with you that this is one of the reasons why we are having these webinars, that we want to go public and have also an influence on health policy where more and more now the focus gets into life phase approach and into a more holistic, comprehensive healthcare systems, especially for women. Maybe
Yeah, I
it's a lack.
strongly believe, Johannes, that as you know very well, because you are a master in this field, sexuality is so important also for other dimension of physical and mental health and vice versa. It should be a goal to protect also sexual health across the aging process, especially now that with this increase in longevity everywhere. But what is really essential to understand that is the biopsychosocial approach that counts, but you cannot have a satisfactory sex life. Yeah, maybe this can be mental, emotionally, but if you want to have a sexual activity, we really need to protect the genital from the urogenital involution. And in my view, we really need to think about that we should protect the genital even in a more preventive way, if I may say, because what we have found in our research, we published a study in which we saw that women they are treated for VDA and GSM, they have more severe symptoms. And when the symptoms they are so severe, you cannot improve even the tissue anymore, and you don't improve the sexuality because the vicious circle is already there. So probably we have to start protecting the urogenital tissue and the vulvovaginal tissue already when the symptoms are mild, because we know that these women they will age. So it should be more a preventive strategy. This is really my view.
Are you saying that, sorry, are you saying that it is irreversible if we come too late?
I mean, you can gain some benefit. You
Mm.
can go back to some kind of trophism. We have data that if you start, for example, low dose estradiol, 10 microgram, before 60 or after 60, you can see an improvement in the tissue. But if you start over 60, the improvement you will obtain is never as if you start earlier, okay? Because the tissue cannot really regenerate. And this is the reason why probably we should combine also with some regenerative medicine. But as you know very well, these treatments are very expensive, they are not so well controlled in studies, and they are not available to everybody. So, in my view, we have to think about local estrogen therapy more as a preventive strategy of something that can come. And as soon as you see mild symptomatology, if women they really want to protect their urogenital health and sexual health, maybe they should start as soon as they see the symptom. Whereas, as you know very well, products they are approved only when women they have moderate and severe symptoms. But you know, this is really something that is subjective. So, in my view, we really need to be more proactive.
Mhm. I have again another question from Peter Erasmus from Durban. The application of either estrogens or DHEA, is it important to apply to the whole vaginal epithelium or just deep?
You know, as you know, when you put deep inside, uh, then you have an absorption that is local. And if you put a suppositories, for example, or a tablet, you will have a widespread effects into the vagina. It may reach also the vulva, but as I tried to tell you, probably sometimes is not enough. And this is the reason we have some studies now suggesting that if you put a cream or a gel into the vestibule, maybe you obtain a better results when you have not only dyspareunia because of poor elasticity of the vaginal canal, because of obliteration of the fornix, etc. But you may have also pain in the introitus, okay? That is something more related, yes, to the trophism, but also to the circulation, to the nerve fibers, to many other different aspects. You have to consider that we always have studied vulvovaginal atrophy as a whole, but probably there are some subcategories of women that feel more the pain into the vulva in comparison to the vagina. But you can use a suppository, you can use a tablet, and you will have an overall effect into the mucosa. It depends on the patient. There are some patients that really prefer to use, for example, estriol gel, because you have also the, let's say, cosmetic and moisturizer effect of the gel, and maybe they don't like the cream because you have some leakage. Remember also preference of the patient is very, very important. And we put this concept into the guideline because otherwise some women, this is the reason why women, they have a low compliance to this treatment. And this is the reason why some women, they can have benefit from oral lospemifen or from menopause hormone therapy if they can use it. And also something I forgot to tell you is that we can combine low dose menopause hormone therapy with estrogen, progestogen, or even with tibolone with low dose local estrogen therapy. We don't have so many data, but it's not dangerous for the woman to combine because for some of them, the dose we use now systemically, they are not enough to obtain good lubrication and good trophies into the genitals.
And there is another question. What is your opinion about vitamin D vaginal use for atrophic vaginitis 3 times weekly for 6 months? With receptors in vagina, there are vitamin D receptors.
I know there are vitamin D receptor. I know there is a trial because we revised the guideline. But you know, the evidence is not strong enough really to say that you can use vitamin D to treat the vaginal atrophy because the quality of the study, there's still not enough strength. But of course, it's a good supplementation, as you know very well, for many different dimensions of women's health. And so it's nice to think that if we use vitamin D for bone health, for cardiometabolic health, we use also for vaginal health. But it's a very good point.
And I come to the last comment because we are at the end. I think the colleague from Turkey mentioned that, government does not pay for different vaginal treatments. And women look for magistral formulas that have no control of dose or content. As IMS, do you have any statement about magistral formulations? Testosterone creams were at the top list besides magistral.
I have to tell you, if I understand that you are talking about compounded, produced by the
Yeah.
pharmacist, etc.
Yeah.
We didn't do a specific statement on this, but in the new guidelines, we really summarize the literature. And my dear friend, I have to tell you, there are not very good evidence that we should use this product because we don't have studies with very well designed placebo control randomized with placebo. You have heard how much the placebo effect is there. But of course, there are some natural estrogen androgen that can be used. I know these products are out there. They cost some money. And we can propose to the women. I'm not against, but you have to understand that there is not enough evidence. So I believe that if the studied products are there and they are safe, why we really need to use compounded products? Because what I don't like really of all this story, I have to tell you, straightforward, is that the communication on this product, it seems that this product, they are safer because they are natural. But I don't think they are safer. They are always hormones. And the difference is that they have not been studied. You have to rely on the pharmacist. You have to rely on the dose that the patient put in there. Maybe they use a lot. I have to tell you, with testosterone cream, I have women they use more because they feel better. But we don't know how much our testosterone cream, how high dose is safe for the woman. And this is always a delicate, a situation in which we have to balance benefit and risk, but we have to do a clear communication to women. I don't like those women, they are on bioidentical and they believe they are not hormones because they are natural. They are hormones, like exactly like the other one. This is my view, my dear friend.
Well, I think that was a very excellent final statement, which is, I think, very important because all over the place, I think there is a lot of misunderstanding and even myths about nature, and it's all nature. But thank you very much again for your excellent statement and contribution.
Thank you, Johannes.
Yeah.
Thank you to everybody.
So I give over to Marion, who would brings me in this slide where you can see our invitation for the Congress in Rome, the Gynecological Endocrinology Congress, the ISCE. Everybody probably knows about it. It will be in March 4 to 6 in 2026. And I can assure you it will again be one of these very, very interesting congresses where we have an enormous international exchange about research, about ideas, about opinions, and about experiences. Thank you very much, and I wish you all a very good day.
Ciao, ciao. Ciao, Johannes. Thank you for
Ciao.
sharing.
Ciao,
Ciao.
Rossella. Ciao.
Ciao.